hello everybody, and welcome to one more of our webinars in our webinar series. Today we are going to focus on vestibular, and the title of today is an optimized workflow for vestibular testing. The presenter today is one of our well-known audiologists from OTOMETRICS. So it's Maggie. Her name is Magdalena, but we call her Maggie. And she's the product manager for the balance area in OTOMETRICS. My name is Mariana Rosling, and I'm the education and training manager at OTOMETRICS. Just a little bit of housekeeping. So all participants are mute to reduce background noise. It's possible to ask questions during the webinar, but you have to look at your right side. You have a question box. If you write your question there, I will be able to read in the end of the session. So Maggie will do her presentation through, and then in the end of the session, I will pick some of the questions that come up, and then we will ask her. If there's too many questions and we don't have time to go through all the questions, we will send to you an answer for your question after the webinar. If you have any problems, you also have in the question box, you can write it to me, or you can chat with me directly, and then I will try to help you during the webinar. Okay, Maggie, welcome. I'm really, really happy that you will spend the time with us today and talk a little bit about the balance area, which is an area that I think a lot of people need support on. So now I'm gonna give you the presenter so we can see your screen, and welcome, and again, thank you.
All right, thank you, Mariana, and good morning or good afternoon or good evening, wherever in the world you are calling us in from. My name is Maggie Boorazanes, as Mariana said, and I'm a balance product manager with OTOMETRICS, and I've been an audiologist for just over 10 years now. And so I know what it's like to be on the clinician side of it. And I also know what it's like to try to sit there and say, okay, now what do I do and how do I manage my patient? So we're going to go through and we're going to kind of talk to you about some of the things to consider as you're making these choices, because it's not usually a straightforward choice, unfortunately. So as we go through this, we're going to talk about some of the tests that are currently available for vestibular assessment. You know, I think a lot of people are familiar with VNG, but there's often just a little bit more out there to do. So we'll talk a little bit about the generalities of the test, maybe why you should consider one test over another. And we also want to talk about the ICS impulse and some evoked potentials, because those are some products out there that I think we get so focused on VNG, posturography, that we forget some of the extra tools that we've got available. And then we're also going to review some potential modified workflows. For me, when I learn, it's great when someone tells me, you know, here's something that you could do, but I always like having an example. I feel like I learn better that way. So we're going to keep going through here. So let's just kind of briefly talk about which tests we have and maybe some of the benefits that are around them. So we all know VNG, ENG. We know at this test we're really trying to decide, is it central, peripheral, or maybe non-localizing? And we also know that 60% of VNGs that are performed, even when the patient is saying I'm dizzy, come out as being normal. There's rotary chair. This is something that's out there. It can be fairly expensive. It also has a very large footprint, meaning it can take up a lot of area in your clinic. Posturography is another test that we have out there now, and that's exciting. That's been out for a while, and now that we are partnered with Natus, we have access to that technology, and it's exciting to see all the things that people are really doing with it. And the more I talk to people, the more I find out that this test is being done. We have the ICS impulse device, and it's something I think of not just for doing video head impulse test, but a lot of our system can do so much more than just a video head impulse test. You can use it to really be this multi-dimensional tool that you can kind of maybe even use as an entry point to vestibular testing. And then there's evoked potentials such as electrocochleography or ECOG, the auditory brainstem response or ABR, as well as vestibular evoked myogenic potentials. And everything is out there, but I think the thing that I I like to kind of drive home is that there's not one perfect test. You know, if you were testing someone's hearing, for example, you wouldn't just do otoacoustic emissions and say, I'm done. You know, maybe if you were trying to screen someone and decide, do I need to do more testings, you might take that test and say, okay, well, you passed your OAE, so maybe I don't, you know, necessarily have to do diagnostics on you. But if someone were presenting and saying, I have concerns for my hearing, you wouldn't hang your hat on just the one test. And I think we can start to think about vestibular testing that way as well. You know, you don't just have to do a VNG, you don't just have to do a VEMP. There's so many more things to consider and take home with you. So as we look at the current status of vestibular testing, you know, for those of us who are very familiar with VNG, we're doing oculomotor testing. So the patient is being told to follow a target with their eyes, and we're using those eyes as a window to the inner ear to see if we see any central sign of lesion. With positional testing, we're putting your body into different positions to see if we can trigger any abnormal eye movement and then decide what kind of pattern that eye movement follows. And then at the end, you're doing calorics, which is the hot and cold air into the ear. And this is usually a peripheral finding, but for example, if someone has no caloric response, we know that they have possibly bilateral vestibular loss, and you're going to need to do more testing beyond that point. This we have just covered in another slide, and I thought I'd actually taken out, but it's kind of summarizing everything we've just said. And I think we kind of pick a little bit on VNG, rotary chair, and posturography just because we know so many more people are using them regularly. And again, just kind of driving home that a lot of these tests have their good points, but not every test is perfect for every patient or for every clinic to have at hand either. So as we go through, it's nice for me to sit there and tell you to walk away from things that you've been doing standardly, but I think it's better for me to actually give you maybe some alternatives to what else you can do. When you think about it, the American Academy of Otolaryngology Head and Neck Surgery in 2017 actually put out a position paper about BPPV testing and treatment. And their paper recommends that if you see someone and you suspect that they have paroxysmal positional vertigo, that what you should do is immediately test them for it and treat them if you can. So based on that, it would be recommended that if you're seeing a patient who's dizzy, take a case history, have them undergo a physical exam with a physician. And then if you're suspecting BPPV, just go ahead and do the Dix-Hallpike or do another test that you think will test them for BPPV. We know that even the Dix-Hallpike, you know, you might need to modify depending on the patient's needs and what they have going on. If you're not suspecting BPPV, spontaneous and gaze testing can help you document to see if there's any pattern of a gaze-evoked nystagmus. You could do the head impulse test, VEMP, and then a hearing exam. And then there's additional tests that are out there too, you know, caloric and ECOG, but what I would always encourage you to do is to think to yourself, you know, I'm the professional, and if I'm not seeing, you know, something that's fitting this pattern, I need to start thinking about other tests. But you can also kind of take this as your little entry point to maybe kind of check off a few boxes before you start going through an entire test battery that may not yield helpful information. So it is just after 7 o'clock in the morning here in Chicago, so I'm going to start my day with a nice bright quiz. So if it's later in your day, you're going to end your day with a quiz. But if a patient came in and they were complaining of brief symptoms of vertigo that might be induced by rapid changes in head movement, like bending up and down, or maybe more specifically rolling over in bed, they think the vertigo lasts about 30 seconds to 2 minutes, but maybe it feels like forever to that person. And between the attacks, they're also feeling just a little off, you know, not feeling quite up to the task. You might start to wonder in your head what this disorder might be. So I'm going to give you just a second to sit there and kind of formulate what disorder you might suspect that they have. And if you're suspecting that they're having benign paroxysmal positional vertigo, based on the symptom presentation, that would be very classic of this disorder. So again, your workflow would be to take a case history, have that person undergo a physical exam, and then maybe do a Dix-Hallpike or another positional test, and then a repositioning maneuver. All right. So just because it's early and I like a good quiz, I used to work at a university, so it's always fun to quiz people. Let's think about another disorder that's out there. And I like presenting the symptoms first because when you're meeting the patient, they don't come in and tell you I have X disorder. So let's kind of start to think about if you were seeing these symptoms, what might you think the person had? So this person comes in after you've been the miracle worker and you fixed someone's BPPV. They're saying, I've got this really long standing rotational vertigo. And when we say prolonged, we're really thinking I've had this maybe for quite some time. The symptoms are getting worse, especially when I move my head. They're maybe noticing postural imbalance. To say on the side of lesion is maybe a little unfair on my part. Let's just pretend it's on the left. They're having nausea. They get spontaneous nystagmus, or they're feeling that their eyes are moving. And when it says toward the good ear, this might even be something that someone had put into a history for you. So this might be combined information from the patient and the physician. So I'm going to give you a second to think about what the disorder may be. And if you are thinking of vestibular neuritis, you are spot on. That's kind of what I would have expected this to present as. And when you're doing, or when you're testing someone who might be having suspected vestibular neuritis, again, you're starting with the case history, a physical exam. But in this case, look for any presence of spontaneous nystagmus first. You could then do your head impulse because that's going to tell you how each of the 6 semicircular canals are involved. And then you could perform VEMP. And an instance here where impulse might be or video head impulse testing might be a better option to calorics is that you have 6 semicircular canals, as we're all very well aware of. And when we're looking at calorics, we're really only looking at that lateral canal. So if that test were to come back as normal, you still have 4 other canals that could be involved that have been overlooked. And if you were to see that the problem had been that person's left anterior semicircular canal, you would then not really want to do calorics because that might not give you much more information because you're not even testing the canal that's involved. So just to kind of also give you a little bit of the logic of, okay, where would you go with it? That to me would be what you would want to do. Well, it's all well and good to have an idea of what you would do for peripheral disorders, but we know that people can come in with a central disorder as well. So again, always starting with a case history, and starting to think about key points in there that might tell you that someone is having a central disorder. This is usually something that's been a little bit more long-standing. Maybe it's been lasting for years. They might have some other symptoms that kind of make you think, okay, well, maybe it's not BPPV. This isn't just induced by head movement. This is kind of gradually coming on. You'd want them to have a neurological exam because you really want to look at the central pathways and have an idea of where that central issue may be occurring. A physical exam is always good here too. And then again, looking at gaze and spontaneous first to see if there's a pattern that would be a central pattern. Looking at the VOR response with visually enhanced testing, or by looking for suppression. Skew deviation is also another very helpful test here to do, and then doing head impulse, because again, looking to see are any peripheral end organs involved as well. Honestly, when we look at this, it's saying to maybe do an additional diagnostic test and consider a hearing exam as additional. I actually, in this situation, I like to get a hearing test on every person I've ever done a balance test on. I think of it personally as a little bit less of an optional test and something that's part of a workflow, because if someone can present a hearing loss that also fits a central pattern, that will probably help you in your differential diagnosis as well. And it's also good to start looking to see if you're seeing patterns that are central or peripheral, even just beyond the balance system. And then VEMP is another test that could be used as well. All right, so now that we've kind of given you some food for thought, maybe it's your afternoon snack or your breakfast, let's start to give you some other symptoms that you can start to think about what it might be. So this might be a patient who comes in with a loss of sensitivity or a change in sensation, like maybe they're feeling tingling or pins and needles or numbness. If you've ever had your foot fall asleep, maybe that kind of a feeling, but knowing your foot hadn't fallen asleep. Any muscle weakness, pronounced reflexes, maybe they're having muscle spasms and difficulty moving. This person might be noticing difficulty with coordination and balance, so kind of getting all of your like body parts to move in a way where you can walk productively. And this person might also report problems with speech or swallowing, nystagmus, and maybe even double vision. You know, some changes in vision could definitely be reported by someone with a central lesion. I'll kind of let you take a minute to think about what this might be as well. And this is a little bit, I think, of a trickier one. This would be someone who is starting to present with multiple sclerosis plaques. And the first time I saw symptoms like this, I actually saw them, they were very similar. They weren't quite the same. It was someone who actually had NF2, so neurofibromatosis type 2. He was 16-year-old boy though, however. This might be something you started to see in someone in their late 20s, early 30s, especially among the female population. So you kind of have to also take into your mind, you know, how old is this patient? What is their gender? Because we know that certain diseases and disease processes tend to affect some populations more than other. So another thing you'd want to keep in your mind. So with this person where you had suspected multiple sclerosis attacks, this would be a suggested workflow that's there. So if you're just isolating their balance system and thinking about what you would do as that audiologist or technician who are seeing the patient, this could be a recommended workflow for that. And again, I would kind of consider throwing in a hearing test as well. I would actually definitely have done a hearing test to support a central pattern, because if you were thinking, well, is this multiple sclerosis or NF2, you would want to start to sit there and say, okay, well, you know, how does acoustic reflexes look? How do otoacoustic emissions look? You know, if this person is noticing some of their other sensory issues depleting, it might not be a bad idea to check hearing, because maybe hearing is kind of being overlooked among the other things that are going on. All right. So another little quiz this morning. The person comes in, they're saying I have episodic or positional vertigo. So you might start to think BPPV, but this person is also saying, you know, overall, I just really feel off balance. I have this crazy ringing in my ear, and it seems like the hearing has changed in one ear where I can't hold the phone up to that ear. That might be a real hallmark of I can use the phone on my right ear, but not my left ear. So as you're starting to hear this, I'll give you a minute to think about what you think it could be. And this person I would suspect to have a vestibular schwannoma. And to me as an audiologist, the asymmetric hearing loss and the tinnitus would have been the things where I would have thought, you know, this is really more than just BPPV. That to me kind of would have been the red flag. And then this would be the workflow that we would recommend to come from that. So again, always including a hearing exam, but especially in this case where someone says, hey, the hearing seems to be different in one ear than another. So as an audiologist, it's always my gut feeling to say, let's test your hearing. But I think especially if you are outside of the audiology field and you're listening to this, because these two mechanisms are so closely involved, to me, it's always a good idea just to make sure their hearing is intact as well, because again, it can help you support a central pattern, or it might also just give you a heads up too that this patient does have hearing loss, and maybe that impacts how you're going to interact with them coming in the future. You know, oh, Mr. Patient, let's remember your hearing aids, or good thing we've got your hearing aids today. We'll have a better time going through your exercises. So right now, we're going to take it from thinking into diagnosis mode into more of thinking in terms of your equipment mode. You know, what kind of tools do you have available to you? Since we all know V&G pretty well, I think I'd like to talk a lot about what our ICS Impulse goggle can do, because I think there are some very special things that we have available. The goggle was originally designed for video head impulse testing, so that's why we only have the one eye, because we knew that if we had one eye available, it was optimized at a weight that would work well. So when we go to do things like monocular Frenzel or video recording of the eye, we only have one eye because we only have one camera on this goggle to make another test work the best it can. But this is a really nice feature that actually comes built in with the goggle, where you're able to record the eye and the room simultaneously. So this might be nice even for taking a case history, you know, hearing what the patient is saying and being able to play back. We have a feature called DVR where I like to rewind things sometimes if I'm just kind of thinking of something else for just a quick second. It's nice to play it back. Well, now you get to DVR your case history session, or if there's a test in the device that you don't have and you just want to record something, you would be able to do that with this feature. But as we had mentioned before, the ICS Impulse Goggle is really all about the video head impulse test. So for those of you who aren't doing video head impulse testing, or maybe saying, I'm just starting to learn about this, I'm not as familiar with this, the test was originally described 30 years ago in 1988 by Dr. Halmagyi and Dr. Kurthoys as a bedside test of the VOR. So if I can move your head quickly from side to side, can you maintain your focus on a given point? Usually the tester's nose, right? Because you're right up there in the person's face. And they were able, with this test, to get ear-specific and canal-specific information that could say, is it your vestibulo-ocular reflex that's deficient, or might it not be that? And when you were doing bedside testing was good, but you had no feedback on how fast you were moving the head, because if you're not going over 100 degrees per second, you're not isolating the VOR. And you also don't always get to measure all the eye movement that you need to if you're only using your eyes. We know there are 3 different kinds of saccades that can happen. And one of them, the covert saccade, can be incredibly difficult to test with your eyes. And actually the third saccade is normal eye movement. So the third type of eye movement you're looking for is the absence of saccades. But covert saccades, which are happening during the head movement, can almost present like no catch-up saccade at all. So you know, it's kind of a situation where you want to have a camera to be able to help you detect this. You want to have something there that's going to work with you. So again, we're going to look at the ratio of eye velocity to head velocity as we move the head left, right, and on an off-axis plane, and we're going to see if we measure any of those saccades. And this whole time, the patient is fixating on an object. The SHIMP, or suppression head impulse paradigm, is something that we can do with our VHIT equipment. We were the first people to be able to offer that. And it's kind of offering more information about the VOR, but it's offering it in a very complementary way. So you're going to look to see if catch-up saccades are present or absent, but you're going to do it in a slightly different way. So with VHIT, the target is fixed on the wall and the tester is moving your head quickly, and we're hoping not to see saccades. With SHIMP, the patient is following a target that's projected from the goggle while the tester moves their head, and we're hoping to see saccades. So it's kind of an opposite but complementary information that can help to support that diagnosis. And right now it's only done in the lateral plane. So the big difference, I think, when you're thinking of this earth fixed, or is it coming from the head in terms of the target? And then am I seeing saccades and I want to see saccades, or am I not seeing saccades and I didn't want to see saccades? Those would be the things that we can basically share about this test at this point. And then here's a test of our device being validated against the scleral search coil. And we are proud to say that we are still the only manufacturer on the market that has done that for all 6 semicircular canals. So a lot of people will sit there and say, if I'm assessing semicircular canal function and I'm going between calorics and VHIT, why would I need to do impulse? Well, both are ear specific, but again, with the impulse, you're going into all 6 semicircular canals, whereas with V and G, E and G, you're really only looking at the lateral canal with your caloric test. We know with calorics, you really don't want to do that test on anyone who has a middle ear issue or a tympanic membrane perforation, but you can go through and you can do that on impulse. Some people will not tolerate calorics because it's very stressful, or they get scared, or they become extremely dizzy, and that's going to be much less of a problem for you with the ICS impulse and doing VHIT. You're looking also at a faster head movement that I think is more akin to the movement you might make before you cross the street. You'd quickly look both ways and decide to go, whereas the caloric test is a little bit more of a lower frequency or slower speed stimulus. And with impulse, once you're done moving the person's head, you're generally done stimulating them. Where we know with calorics, you're waiting 3 to 5 minutes between the irrigations, especially if the irrigation hadn't been performed properly. On this screen, you're going to see a summary of the different types of tests that are on the ICS Impulse Positional module, because that's really about looking at BPPV. So if we know this is common and we know that people are saying, hey, if you're suspecting this, do this test first, you have now the ability to put a very lightweight goggle on someone and go through and have user-guided testing to say, hey, you're hitting the right head position, especially something for side lying or maybe even a roll test that you might not be performing standardly. Now you have something that's on your side to help you get through that test a little bit more. And then when it comes to repositioning, you're also going to get that same support in the software, but this is kind of giving you a nice breakdown of what treatment you would use when. So for example, the barbecue roll is for treating lateral canal BPPV. I'm kind of pointing that one out first because I think it's kind of a cute name, but also it's not something I would have standardly done back in my clinical practice. Liberatory and canal repositioning maneuver, or the Sonat and Epley, are there for your anterior and posterior semicircular canals. And again, I've included in this just a nice summary of how to do each test, just so that you have something to kind of fall back to. Coming on this way, these are the tests that are included if you were to buy the oculomotor license for the ICS Impulse. Gaze and spontaneous, I think, are things that we're all pretty familiar with. Skew deviation is a little bit different. You have the patient in a sitting position looking straight ahead, and you alternately cover each eye. And when you do that, you're looking to see if the eye is shifting up or down. And if you're seeing a significant shift in the eye, that is a very strong sign that that patient is having a stroke and would need immediate medical intervention. This is probably a test that's being done in a more acute setting. We're seeing this done in the emergency department more than outpatient. If you're doing this test as an outpatient, immediately get that person into the ER. Saccades are another test that we're offering too, and when we talk saccade, we just talked about saccades in terms of the video head impulse test. That's us moving your head to elicit a rapid eye movement. This is following a target to elicit rapid eye movement. It's very similar to what we're doing with VNG. And then two tests that I learned about as I had come onto Otometrics are VVOR, the Visually Enhanced Vestibulo-Ocular Reflex Test, and the VOR suppression test. So with VVOR, you're going to move the patient's head from side to side while they stare at a fixation dot on the wall. So if you kind of think about VHIT, it's a little like VHIT, but at a much slower speed. And at this point, the person should be able to keep their eye trace on top of their head trace, because as you move the head from side to side, the eye should stand still to maintain gaze, and you're going to see that the eyes are actually moving in order to keep the eyes to the center. And then with VVORS, or with VORS, excuse me, you're looking at the cerebellum and its connections, but now a laser dot is coming onto the wall and you're moving the patient's head with the laser dot. And for this, there should be a relatively flat head tracing because the eyes are maintaining gaze on the dot that you're presenting from the wall. I've also seen this test done at bedside where someone literally has the patient hold their thumb out and stare at their thumb as they rotate from side to side. But we do it with our laser from our ICS Impulse goggle. Torsional nystagmus is another feature that we have for ICS Impulse, and it's another license key that's purchased. And it's not really a module in the software, it's just something that unlocks the power of the software to be able to measure the torsional eye movement. We know that torsional eye nystagmus is a hallmark of BPPV, but if you're not suspecting BPPV and you're seeing it in a gaze-evoked situation, that would be a strong central sign. So you would use this anytime you were using the positional or oculomotor module test to see if you were measuring any sign of that torsional nystagmus, because that's going to help you differentiate, is this central or peripheral? And you might be able to watch that with your eye, but now you also have something to help you quantify that. Coming along here, I know we're running out of time, so I'm going to kind of go through these, but these aren't, I don't think is where as much of the meat are. Evoked potentials are also out there. There's something that can tend to get overlooked. You know, electrocochleography can be very strong for detecting Meniere's disease, or it has been. Kind of depends on if the patient is symptomatic the day you see them or not. VEMP is out there, and there's also the good old neurologic ABR. I still see this as something that's actually out there to be helpful, because if you are looking for something like MS, you want to see that how the integrity is of that central auditory pathway. So that would be another test that would help out with that. Any sort of demyelinating disease can really kind of be there to aid in differential diagnosis. This is showing what ECOG would be looking for. You're going to look for a cochlear microphonic or a baseline, going up to a summating potential or an action potential, and then you're going to kind of look at the ratio of these. So again, as we had mentioned, this is a helpful thing to diagnose with endolymphatic hydrops or Meniere's disease, but it can also be a strong tool for suspected superior semicircular canal dehiscence. And then VEMP is out there too. So VEMP is really helpful for dizzy patients to rule out any sort of otolith organ dysfunction. And also patients who might be coming up with a normal VNG who are still dizzy, this is something that's very easy to add to your evoked potentials equipment and can be another nice tool that you would have available. And then again, ABR, it is part of the auditory test battery, but it's also, again, giving you really good information about the central auditory pathway. So now I've told you about all these tests, and unfortunately, you probably don't have more time to do your testing, but really think about what the patient's telling you and what tests you have, and it might help you to decide which test you start with. You know, maybe getting the more meaningful test done and out of the way first might prevent you from needing that patient to come back, and you might still need that patient to come back, but at least you have some baseline information that's already been done. So if you think about how can I save time, if you were to start by testing for BPPV, you wouldn't need to do a caloric on that patient. So you'd be maybe saving a good amount of time there. Same thing with vestibular neuritis. If it's not that lateral semicircular canal that's involved, you're going to have more time available. And I think this applies beyond just rethinking, am I doing calorics or not? It could be other tests that you're incorporating too. You know, where can I start to think about prioritizing one test over another to help me save some time? And a question I get sometimes as well, it's very nice that you've told me all these things, Maggie, that's great, but what is the best tool? And I think we have to kind of come back to the idea that there is no one perfect tool. I think in any discipline for assessing a certain diagnosis, you know, you might always want to still have a test battery. And I think a test battery is helpful because you're thinking comprehensively. But you're also able to show, well, I saw this, but now I didn't see that. But maybe being able to tell yourself, okay, I strongly suspect it's X, I strongly suspect this is BPPV. I'm going to start with a Dix-Hallpike. Great. And you may incorporate gaze testing to that just to show that there is no other central sign going on. I think ultimately your knowledge and clinical judgment are the best tools that you can have for yourself. So I always, for myself, try to keep as much in touch with the literature as I can. But I think creating an evidence-based protocol, so understanding to yourself why you're including a test is very helpful. Keep attending conferences. I don't just say that because OTOMETRICS sponsors conferences. I say that because I think it's helpful to be out in the world and see other providers and maybe be able to casually ask someone a question or make even a contact where you can kind of start to work together on certain ideas. I think that's probably the strongest thing I see that comes out of conventions. I think the continuing education is always very helpful, but sometimes it's more of the people you meet that you get to talk to. And then even getting an awareness for different reimbursement codes and procedures. I know a lot of the time we're thinking, how much am I being paid for what I'm doing? And in some areas of the world, you might prioritize tests on your reimbursement and kind of justifying your presence in a certain situation. And that's totally understandable too. And that always will have to come into play because if you can't afford to do your job, you can't be there to do your job. All right, so now I'm going to open it up to questions. We're right at the 31-minute mark from my side. What can we answer for you in a few minutes?
First of all, Maggie, I would like to say thank you for a really, really good presentation. I think you went through a lot of things and you explained in a very, very good way. So thank you so much for that. Now I have some questions that came in during your speak. The first one was, I'm trying to get it open. It's hard here. Can vestibular, the question was if you have seen vestibular schwannoma in symmetrical hearing loss.
You know, I personally haven't seen that, and a lot of the literature I've read, it usually shows the asymmetric loss as kind of one of the hallmark things, but I don't think that means that it couldn't possibly be in both ears, and that both ears couldn't have an impacted hearing loss. And then if someone is having bilateral vestibular schwannoma, that would be, to me, a sign that they might have neurofibromatosis part 2 or type 2. So obviously CT and imaging would really help you make bigger decisions, but I don't see why they couldn't possibly have loss in both ears.
No, and one of we just have to remember sometimes also only when they have one side, the difference in the hearing loss can be very, very small. And it's by looking at reflex or looking at other tests that you do, you can really see, oh, something is going on here. I remember when I worked at the hospital, the biggest schwannoma I found, it was the smallest difference in the hearing loss. So it was, yeah, we were not expecting that.
Oh my gosh.
Yeah, we were really surprised.
But no, you're right, because when you think of it too, you typically see only the highs impacted, or yeah, oh my gosh.
Yeah.
Go figure. Amazing how the body manifests things in so many different ways, isn't it?
Yeah. What makes your VHIT different from other VHIT systems besides comparison to surgical?
You know, I think it's also the fact that we have the lightest goggle on the market right now at 60 grams. And I think that comes into play too, as well as the fact that our camera is fixed, because you have less moving parts that can be less prone to having any sort of extra slippage or camera movement. But I would think if you talk to our competitor, they have reasons for why they have those features in place. So I would, again, you know, kind of think about what are you looking for, but I think the fixed camera and the lightweight goggle are the other two features that we have that are really kind of helping us to get a bit of a better measurement there.
And also the gain calculation, right, Maggie? We calculate the gain
we're calculating area under the curve.
And there is a research from Japan that shows that the way we calculate is more precise, and it gives you a better idea of what's going on. So pick up on smaller differences.
Yes, that has definitely been very well documented too.
Can VEMP replace VENG to avoid patient dizziness?
I don't ever think about using one tool maybe to replace the other, and I would think about too what's causing that patient's dizziness. If they have a canal dehiscence and then you're inducing a loud sound to their ear canal, I could see that as a trigger for dizziness, whereas a VNG, ENG might not cause that. So kind of think again too maybe about all the patient's symptoms. I don't know, Mariana, would you add anything to that?
No, I agree with you. No, I think, yeah. I'm actually trying to find out also, there's a lot of questions coming in, Maggie, so I'm trying to find out how
you might
I'm
have to send them through email. Okay.
Yeah. There's one, will the slides
That's great though,
be
I'm glad there's
available?
questions.
Would you make the slides available?
We can make them available.
We could do an
sure, I can send them
a PDF, and then we can send to the list of participants if you want that. If you don't receive, please write me a mail and I will send it to you. There is some standards for the finding of SVVOR because it is very, very common to find saccades during the test. I think it's VVOR and VVORS they are asking for here. So do we have any
I know there's some ongoing research with that right now. Right now, as OTOMETRICS, we don't offer a standard for that, but David Schmolowitz has been doing a lot of work with it. I know, and I know that's something he's continuing to look at out of Australia. So if you can.
Yes, and I know that there's a lot of other people working on standards also. This is a new test, so I think we have to have a little patience. As when we started having the heading pulse, we didn't have the normative data yet, and we have it now. And I think it's the same what's going on with VVOR and the VORS, also for explanation on exactly what's going on when we are testing. I know there's a lot of research going on in that area as well.
Yeah, which is exciting. I think that's what's cool about that tool too.
Yeah. I have another one, and this will be the last one, Maggie. Hi, congratulations. It was very nice, and a very nice presentation. I have experience with VHIT in the emergency department. I use it for the differentiation of beginning and dangerous conditions when the patient has acute vestibular syndrome. I find it very useful. I think it works because it's quick and safe. Have you got other experience?
Do I have like personally, have I had experience going into the emergency department with it, or are we looking for others who have had that?
I think it's experience on the, I think it's if we have heard of others. I don't know, that's the information I have here.
Okay, there are other people who are doing it. Famously, David Newman-Toker at Johns Hopkins is using it in the AVERT study, but I also know that there are studies going on all over the world to look at it. And I think depending on the study, if you were to do like a PubMed search or an Ovid search on it, you will see lots of articles come up, and I would kind of look at the intent of the article with what they were trying to accomplish, because a lot of them have some different goals. So I know it's something that's becoming increasingly common because I keep hearing about it from different users and different people who are saying, how can I start this up? So you're definitely not alone out there with what you're doing.
Exactly, and some of these doctors came with different test batteries to test for other kinds of diseases as well. So I will recommend you to look in the literature, because there's especially from Johns Hopkins, right, Maggie? There's a lot there.
Yep.
Yeah.
As well as from Jorge Cata too.
Yeah. Exactly.
He's been working very closely with that study, but he's done other studies as well around that.
Yeah. Okay, then I think we got all the questions. If you send me the PDF, I will try to send for the people that participate in the webinar, so it's not out there for everybody. Maggie, once more, really
Excellent.
thank you. It was a really, really good presentation. Thank you very much.
Oh, you're welcome. Thank you.
Yeah.
All right, thank you all. Have a great day. Thank you so much, Mariana.
Okay, bye.
Bye.